Thanks very much for that kind introduction, and it's a pleasure to be here in Ottawa, although the day's a bit rainy and not sunny and maybe a few snowflakes, which is probably a good thing perhaps for weekend traveling. Hopefully I'm going to give you a broad perspective of malnutrition in hospital as well as what we've done in terms of the CMTF study. And so just first off, who is Canadian Malnutrition Task Force? I'm just one of many people that have been working on this study for the last 3 years. And some of the names I'm sure you might recognize. It's quite a group that we have that are experts in nutrition and in screening. And there's two of us that are academics, Ellen Pett and myself. So we're sort of the epidemiologists, nutritionist folks on the team. Our vision is to advance nutrition care in adult and pediatric patients through research, education, and interdisciplinary collaboration in Canada. I'm just going to be sharing with you today the adult arm of the study, but there is a pediatric arm as well that's ongoing. Our learning objectives today are to provide an overview of hospital malnutrition, its contributing factors, and the impact of malnutrition on patient outcomes, to discuss the relevance of findings on current nutrition care in Canadian hospitals, to discuss best practice methods for achieving care goals in the hospital environment. And specifically, I want to cover off nutrition status and prevalence, impact on length of stay, 30-day readmission and mortality rate, identification of food access issues that we've seen in hospitals in Canada, as well as physician and nurse perspectives on nutrition care processes in our Canadian hospitals, as well a little bit about perspectives of nutrition care personnel on what are the barriers and facilitators of good nutrition care, and then finally give you a little bit of a snippet around information on our CMTF screening tool, which might be part of a process in terms of helping people to identify and treat malnutrition in hospital settings. So just to start off with, I want to clarify what we think of when we consider malnutrition. Malnutrition is quite diverse, and as the title it suggests, it's everything from obesity down to undernutrition. But in this specific presentation, we're carving off the view of undernutrition specifically and looking at inflammation versus non-inflammation excuse me, as part of that process. And so people can have undernutrition without inflammation, and others can have an inflammatory component on top of that nutrition, which could be due to the malnutrition or disease states. And you have to understand that those who do have inflammation likely have some other things going on in the body that affect their ability to absorb nutrients and use nutrients in a way that we would anticipate. If we think about the prevalence of malnutrition worldwide, using subjective global assessment, which is the only criterion that is standardized and valid and reliable, if using that assessment we see a prevalence anywhere from 28 to 76%, depending on the setting. So, for example, in geriatric hospitals, you'll see a much higher prevalence. In Canada, at the time of this study, there was no single study that looked beyond one hospital in terms of looking at the prevalence of malnutrition. And in that study, it identifies 69% having moderate to severe malnutrition using SGA. Malnutrition, as we know, has lots of effects. Morbidity is increased, wound healing is affected, infections are more likely to occur, complications as well as decreased convalescence. All those impact the quality of life of the patient, but also they have significant cost implications. So length of stay affects patient flow through the system, increased treatment needs, and obviously increased mortality as well. So what do we know about the costs of malnutrition? I've just pulled together some relatively recent studies looking at the costs. And we see that in a few studies that have looked at this in comparison to well-nourished patients, persons that are well-nourished cost about 60% more to the system. This cost is independent of disease state, and this is important to note. In this one very good quality study done by LIM, they actually looked within diagnostic codes for those that were malnourished and those that were well-nourished and compared their costs. So they controlled for the disease state, which is really important because that obviously has an impact as well on care outcomes, right? But in that study, where they controlled in such a nice way for disease state, they still found a higher cost of malnutrition. This cost is often driven by the length of stay, which is anywhere from 2 to 6 days longer. And we know that if people do develop malnutrition during the hospital stay, that is even worse in terms of length of stay outcome. And this is a unique study. Most studies just look at admission, what's going on with individuals, and then when they leave the hospital. This study actually looked at, this small study here from Brazil, looked at people who became malnourished during the hospital stay and how that impacted their outcome. We know that readmission within 2 weeks is about 2 times greater for malnourished patients as well, and mortality is increased 7-fold. This is just a smattering of studies. They all say the same thing generally, that malnutrition is not good when it comes to cost and quality of life of patients. So then you're probably asking, well, can we do anything about it in the hospital sector? Of course we can. Again, just pulling a few key articles together. A recent economic analysis looked at hospital episodes in the U.S., and this was a very nice data set because it had access to about 20% of the patient episodes in the U.S., and identified that of those that received oral nutrition supplements, that's the only thing that they were looking at, not prescribed diets or other things, something they could identify through the way that they register costs in the hospital. They identified that those individuals, when you control for age and gender and disease state, hospital that they were in, the region that they were in, all those things controlled for, the person getting the ONS actually cost the system less, in terms of about $5,000. Outside of ONS, there's other things that we know work. Dietitians, there's been about 7 clinical trials, RCTs, that have shown without a doubt that a dietitian, because they individualize a treatment, whatever that may be, it may be snacks between meals, it may be increased monitoring, the diet prescription might be use of oral nutrition supplements, enteral parental nutrition, whatever it may be, when the dietitian is put in place for people that are malnourished, they improve food intake and outcomes for those patients. Things like protected meal times also seem to suggest that there's improvements in terms of food intake and outcomes for the patients. The challenge with the protected meal times is that not everybody implements it fully. And so we can talk more about that in the discussion period, how you would implement something like this to change practices in a hospital. And then finally, probably the greatest evidence that we have that nutrition impacts outcome is two very nice studies done in ICU patients, where they put into place guidelines that focused in on nutrition care of patients and identified that those who received early nutrition support in that setting had better outcomes. So in Canada, as in the rest of the developed world, we have some key things that are driving why we see malnutrition in our hospitals and might not be being addressed. For example, many patients come into hospital having lost weight in the community, which means that the hospital is just one episode in the malnutrition journey for these folks. We have to think about pre-admission as well as discharge in terms of dealing with this issue. We know that many of our patients as well are over the age of 65, and because of some of the challenges around food access with older adults, around interest in eating or perhaps appetite and sarcopenia, this group is especially prone to malnutrition. At admission, in general, we know that people aren't screening the way that they should be, and in this study we tried to identify what is actually going on. Healthcare professionals, there's often a shortage, depending on the different roles. For dietitians, for example, or in some centers, dietetics are not available either. So all these different people that can be part of a nutrition care pathway may not be there in sufficient numbers to actually address the need. We know that typically outside of ICU there aren't clear protocols around how to address malnutrition, which leaves interpretation to the individual site or community about how they're going to address this, which is a challenge then, because then we have very fractured practices. And then of course people come into acute care sick, that's why they're there. So there is this underlying disease that we have to take into account as well that affects the recovery in terms of nutrition as well as disease state. During hospitalization, I'm sure I don't have to tell you these things, but we do things to people that actually can lead to malnutrition. So we leave them at NPO for a period of time, for example, waiting for an elective surgery or a surgery that has to be another surgery post their first one because they had an infection or whatever may be happening. We have issues with people being carted off to MRIs or CT scans and missing their meal, and there is no food available perhaps to feed them outside of that time frame. A big issue is the fact that we don't know who's doing what when, and so things are not being caught. Are people watching that someone hasn't eaten their meal for 3 days? So those things are being missed, and we'll show you data that actually does show this as well. And then finally, lack of nutritional interventions. So dietitians are not the only outlet for treatment. We have to think differently about how we address malnutrition. There's no way that every dietitian or a dietitian can see every malnourished patient in a hospital. It's infeasible. So to think about a model that certainly builds on that expertise, but also thinks about other groups and other roles that can be played by other people in the multidisciplinary team. So we wanted to do a study that looked at the pan-Canadian prevalence of hospital malnutrition, what the nutrition care was like in Canada, because we really don't know at the time when we were doing the study, and how does it affect patient outcomes. These are our detailed study objectives. I'll just highlight a few that we're going to cover off today. We're going to look at the prevalence of malnutrition and key outcomes. We're also going to talk about the change in nutritional status during admission, using SGA as our criterion for determining nutritional status. We're going to briefly describe the practice of malnutrition from the perspective of physicians and nurses as well as nutrition care professionals, and what are the gaps they see in the system. And then just a little bit talk about our nutrition risk screening tool and where we're at with that. So just a little bit of an overview around the protocol. This is a prospective cohort study. So unlike many studies done on hospital malnutrition, which are cross-sectional, we actually follow patients through their entire admission of hospitalization and 30 days post-discharge. We consecutively we recruited people to the study who were consecutive admissions, and we had quite a detailed protocol about how we would do this. We didn't overload the site coordinators who were doing the data collection. To be eligible, people had to be in the hospital for at least 2 days and in a medical and surgical unit. We weren't including people, obviously, from these other units like psychiatry and ICU. We included data from 18 academic and community hospitals, large and small. Large hospitals provided 60 patients, and small hospitals provided 40, and 8 provinces were covered. Our primary outcome on which we based our power calculations for this analysis were length of stay. But we also collected a variety of other outcomes. I'm just going to be highlighting mortality for you and readmission. This is the most comprehensive study in the world on malnutrition and acute care. So it's nice to know that Canada is the leader. Key things that, I'll just highlight a few key things for you. We've used subjective global assessment, which is the only gold standard around nutrition. And some people may say, well, that's subjective. True. But clinical judgment is what is needed to identify malnutrition. And other things that are screening tools don't necessarily do a full job of that. We did include the NRS 2002 and our own CMTF screening tool to demonstrate the difference in these two tools potentially in terms of sensitivity, and I'll show you a little bit of that data. Lots of anthropometry, C-reactive proteins, so we could delineate those that had an inflammatory component on top of their malnutrition. And we also estimated food intake in 2 different ways. We had the patient self-assess their meal, which is one meal, 3 days in the first week and 3 days subsequent weeks until 4 weeks, and then it stayed longer than 4 weeks, so only 2 days. In addition, we had the site coordinator, who was typically a dietitian, also do a visual estimation of the tray after it was removed from the room. What I'm presenting for you today will be just the patient self-report. The nutrient analysis, you can imagine, is quite labor-intensive to get through, and we're still working on that. In terms of hospital stay, as I said, we had a site coordinator who every 2 days went to the chart to see what happened to the patient. They reweighed them, and they also looked for any adverse events, changes in diet prescription, etc. So we had a very good tracking then of what was going on for the patient during their time. At discharge, we repeated our nutrition assessments, and we also did a patient satisfaction survey, or patient food access survey is a better term for it. And we followed the person up by telephone 30 days later, or their family care partner if we could not find them. Nutrition care process, as I said, we did a survey with physicians and nurses, and we also did focus groups with dietitians and diet techs, menu clerks, and nutrition managers. Just to give you a sense of what subjective global assessment is, it has 2 key components. One is a history provided by the patient in terms of things like gastrointestinal symptoms or stress of disease. Physical is also done looking for changes in the body that are indicative of malnutrition occurring, such as loss of subcutaneous fat, loss of muscle, and edema. A person is classified as well-nourished at A, or B, moderately malnourished, and C, severely malnourished. The Charleston Comorbidity Index is the way that we try to control for disease state. This is, there's several measures that can be used. This is only one that we decided to use because it was pretty easy to use across hospitals and not have to try to pull data from CIHI, for example.
In terms of statistical analyses, I won't go through all the details, but we have a full-time statistician at U of T doing our analyses, so it's pretty good. And lots of detail here. I can go through some of it if you like when we get to some of those points. In terms of patients' demography, over 1,000 patients were entered into the study, and you can see that the median age is over 65, so a good portion are older adults. In terms of ethnicity, the majority self-identify as Canadian. They were able to give three identifiers for themselves, and we just took the first one actually for this analysis here. And depending on the site, some of these hospitals had quite a large Asian population, for example, but overall this is what it looked like. And education, as you would expect in Canada, a very high education level. If you look at primary admitting diagnoses, on the far left-hand side, you see the individual disease states, which we've grossly categorized as CVD, GI, etc. You can see a large proportion of these people were a GI type diagnoses. But on the far right, you see, which I think is the more relevant piece, that people are coming in with more than one diagnosis and that we're having to address. And so more, typically people have 2+ diagnoses. In terms of our admission parameters, Charleston Comorbidity Index on average was 2. We've used medians here, excuse me. And because, of course, this is highly skewed data, but you can see the range up to 17 in terms of their Charleston Comorbidity Index. So it's a cumulative index. The more comorbidity you have, the higher your CCI. Number of medications on average was 10. Number of supplements, this is vitamin mineral supplements, on average was 0. Oral nutritional supplements about 20%. And antibiotics on admission was 42%. So this is a sick population coming into hospital. So if you look at the actual state of malnutrition on admission, well-nourished is the green, which is good. Dark blue is moderate malnutrition, and black is severe malnutrition. So you can see essentially we have 45% malnutrition coming into acute care medical and surgical wards in Canada. So you're probably saying, well, what type of malnutrition is it? Does it have this inflammatory component on it, or is it straight diet-related or starvation-related malnutrition? Basically, this slide shows that when we look at just those with SGA, B, and C, the moderate or severe malnourished, and then put on top of that a CRP greater than 10, which would indicate an inflammatory process, those people make up 3/4 of the patients coming into acute care. So these are complex patients when you think about their nutritional status and trying to address it. Remember this when we talk about why they don't eat potentially later on, because there's likely implications because of that inflammatory process on some of the symptoms we're seeing. So we look at the actual food intake of these patients based on, again, on their self-report during the first week of admission. So we basically averaged the 3 meals that they provided information on in terms of their food intake. We see that the well-nourished, SGA-A, the majority of these folks consume more than 50% of their main plate, which is great. So our well-nourished patients are eating what we provide them. Our people that have more starvation or diet-related malnutrition without an inflammatory component also eat most of the food we provide them. It is the persons that have the malnutrition and the inflammatory component on it, which is most of our patients that are malnourished in this study, they are not eating the food we provide them. They, on average, only 56% are eating more than 50% of the meal. Okay. In overall, 30% or so have a low intake during that first week of admission. Remember that, because we'll find this is an important predictor of outcomes. If we look specifically at change in nutritional status during admission, this is what the slide shows us. So on the left-hand column, you see their SGA at admission, and on the top first row, it's their discharge SGA. And so green means they did well, and orange is not so good, and red is really not good. So basically, first, the well-nourished groups, 80% stayed well-nourished during their admission. On the flip side, though, this means that almost 20% got worse because of something that happened during hospital. Either they didn't eat the food provided, or what we did to them in terms of our procedures or NP or whatever made well-nourished patients malnourished. In terms of moderate malnutrition, about 60% stayed the same during admission. We were able to get about 30% improved, and a few we made worse, about 12%. For severely malnourished, 60% stayed severely malnourished during their mission. We weren't able to move them up in terms of nutritional status. However, 40% we could. So overall, 70% don't change during the hospital stay. And when we come to the length of stay, you'll see probably why that is. It can be a short length of stay. It's hard to change. And this is why I say that we have to think about malnutrition in the hospital is not just in the hospital, before hospital and after hospital we have to think about as well. 14% improve and 14% worsen during their stay. If we look at other parameters outside of subjective global assessment, which is subjective, and people sometimes criticize it because of that, if we look at other parameters which are objective, and we look at admission to discharge, we get a similar sort of viewpoint. So just highlight first off that the significant tests on the far side and in yellow, and those that are significant are highlighted for you. C-reactive protein, we did a very good job of improving that. People went from a median of 28.8 down to 14.4. So whatever we did in hospital dealt with the inflammatory component or whatever was causing the inflammatory component in these folks. Good for us. However, some other things didn't do so well. Hand grip strength, although the median looks quite consistent in this sample size, that's it is significantly different. And the question would be, do you consider that clinically different? That's another question, perhaps. Weight, we saw a decrease in body weight, and you'll say, well, maybe these people had edema. Okay, well, let's look at mid-arm circumference. Typically not influenced by edema, also decreased significantly, as did calf circumference, which is a marker used in older adults actually for sarcopenia. And then finally, body mass index also decreased on average. So our objective measures also show that nutritionally we're not doing as good a job as we should overall. So let's look at outcomes now. On average, people stay less than 7 days in the hospital, which makes sense, right? We're not trying to keep people there long, but a good portion do stay greater than 7 days. Hospital mortality is about 3%, and after discharge, another 2%, so on average around 5%. As an epidemiologist, I didn't think that was a large number, but from my acute care colleagues, they say this is a large number. We need to work on this. And more specifically, the more concerning number, perhaps, is the next one, where we have basically 1 in 5 patients in this study returning to hospital. If we look at does nutrition impact these outcomes, we'll take off first length of stay. And the way that this analysis is done is with the Cox proportional hazards. What you're looking for is the event of discharge. And so the event of discharge you want to be as soon as possible, right? It's not longer. And so we've had to flip our interpretation a little bit so it's understandable. Those variables that are in dark green are significant. We identify these variables through bivariate analyses first off with the outcome of length of stay, and then forced in some key covariates like gender and cancer because we thought these were relevant to the length of stay of individuals. You can see here that gender and cancer do not predict length of stay in this study. Okay. Age does. So younger folks leave the hospital sooner. That's no surprise, I'm sure, to you, right? Those with the Charlson Comorbidity Index less than 3, so not as much comorbidity, also leave the hospital sooner. Again, not surprising, right? However, what is surprising is that if we feed, or if people eat what we provide them, regardless of the nutritional urge during hospitalization, they're not eating perhaps the food that they were provided, getting worse off perhaps. Look as well at the hazard ratio, the size of these. They're all quite consistent, which means that age and comorbidity are no more important to length of stay as nutritional status and food intake. Okay. Let's look now at mortality. We see that persons who are malnourished on admission are 6.4 times more likely to die during the hospital and or the 30-day. I'm going to show you a regression now. We only had 47 deaths, so you can't model a lot when you have that few deaths in terms of trying to understand the predictors. So we forced in the things that we thought were most important to death. Age is the one single factor that leads to death, right? We all know that. The older you are, you're more likely to die no matter who you are and what's going on. And in this sense, comorbidity should be also the major predictor for death. So we see here that in fact these things are all significant, but also is nutritional status on admission. And here we have odds ratios, and look at the size of those odd ratios again. Here you see that being malnourished is a more important predictor than your age if you come into hospital and are malnourished. Okay? That's what the odds ratio tells us, the size of these effects, okay? It also says that malnutrition is more important than morbidity in terms of mortality in this sample. That's controlling for the morbidity, okay? That's how regression analyses work. So removing the effect of disease, nutrition itself is more important. Let's move on to readmission status. I don't have a regression to follow up on this, but just to give you a sense of people that are well-nourished, more likely to not be readmitted, and people that are malnourished are more likely to be readmitted. And we had 1 in 5 people coming back into hospital between discharge and 30 days. So it's a significant problem. So let's summarize where we're at now. We'll talk then about some of the patient-related factors and nutrition care process factors. So prevalence of malnutrition, to recap, is 45% in Canadian hospitals. Not surprising when we look at the European and other groups that have done SG as well. Remember, the range was anywhere between 30 and 78%, right smack in the middle. So it's not surprising. Malnutrition with inflammation is more prevalent. This is the first study that's actually teased that out. Nutritional status deteriorates in hospital for some. Food intake less than 50% during that first week, and malnutrition on admission are independent predictors of their length of stay. So if we can monitor who's not eating their food during the first week, we can get them out hopefully sooner if we do something in terms of interventions for that group. Malnutrition is an independent predictor of mortality, and malnutrition results in inefficiency. So at discharge, we had about 90% of our patients. All right, so in terms of our patient satisfaction, we have, in general, people are not too dissatisfied with the food, but as you can imagine, going across different hospitals, you'll see different values. For example, some of our hospitals, only 50% say the temperature of the food is appropriate. But over the 18 hospitals, in general, we see not too bad when it comes to patient satisfaction on the sensory quality of the food. However, where we do have a problem is around the barriers to eating and addressing some of these issues with the audience at this point. So, for example, we find that people self-report that they've missed a meal due to a medical procedure 35% of the time. 42% are interrupted during their meal. Those that have disturbed by noise, smell, and activity, 39%. If you look at patients' self-reported difficulties with eating, we have people that are saying 30% of the time they cannot open the food packages, so it addresses this issue here. And if you look just again at the 65 plus, it's a higher level. Looking at self-feeding, cutting food, all of those are challenges for our patient population and predominantly the older adult group. Another concerning issue here is you can see that people are not even being positioned right to eat food. They're laying, or they say that they're laying down in bed and not being positioned properly, about 30% of the time. Perhaps more perplexing to me is that they can't even reach the meal. 20% say they can't even reach the meal that's on the tray that's provided for them. So when they describe why they don't eat, and so this is again looking at their self-report of food intake at one single meal across the three days of the first week. These are the big reasons why they say they're not eating. Poor appetite, sickness, tiredness, pain, etc. And I would counter that we can probably do some things about some of these challenges. So the poor appetite might be driven by the inflammatory component that's going on with many of these individuals who have both inflammation in addition to their malnutrition. When it comes to food access, 30% had food brought in by visitors, 12% felt hungry but no food was available to them, 25% got hungry because time between the meal was too long. I do a lot of work in long-term care as well as chronic care hospitals, and this is not as much an issue there because we have rules about how long someone can be without food in those settings. And so that's part of a challenge here in the acute care setting. 18% when they missed a meal was never given food by staff, and 12% felt hungry but could not ask the staff for food. In terms of our physician survey, we had a 35% response rate with this 6-page survey that was a hard copy. And this may seem like a small response rate, but actually it's pretty good for physicians. And basically, to try to put everything on one slide, the key highlights for you around this group, they identify that practices, only about 30% report that more than 50% of their patients receive a nutritional assessment on admission. However, almost 90% believe this should occur. So basically what this is telling us is that the view of what's happening is not consistent with what should happen based on the physician's perspective. Protocols for identification of malnutrition are reported by 32%, which means that's good for those hospitals, but that means 2/3 of hospitals don't have protocols to address malnutrition, which might lead to then people falling through the gaps and not being identified when they're not eating well. Nutrition knowledge lags behind the interest and perceived importance of nutrition. In terms of nurses, we just include this survey in the second phase, and so it's only including 11 hospitals. Response rate was almost 50%. This is interesting that these nurses did not feel, on average, 55%, that nutrition was a problem. So recognition of malnutrition by this disciplinary group is a bit of a challenge we have to think about. Although almost 100% believe nutrition assessment should occur on admission, and 91% felt that 3 nutrition questions could be part of their assessment. The reason why that's relevant is because most screening tools are 2 or 3 questions. However, they thought the dietitian should be doing the screening. For those that you know about screening, that's not a good use of an expert to have doing a frontline task, right? You need to have the person who's going to see everybody do screening, right? That's what makes efficiencies in the system. So this work has been published in the Journal of Human Nutrition Dietetics, and it's basically it's based on the focus groups we did with hospitals. The first 8 sites were analyzed in detail, but we did do these focus groups in every hospital. And the key things that were identified are that we need a nutrition culture to deal with this issue. It's not a single disciplinary issue, it's the whole hospital. And so thinking about prioritizing nutrition and using teamwork. I'll give you an example. If we have in a hospital a tray getting up to an individual, it stays outside the room, and no one takes that tray into the patient in a timely way, then the food's cold, right? And so the system is falling apart in terms of getting hot food to the patient, and maybe the package is opened, right? We need effective tools to help us through this system. Things like screening, for example, evidence-based protocols, appropriate and quality food, timely and accurate patient information. So just to give you an example about appropriate and quality food. Many of our hospitals had ethnic majority patients. They said, well, because of the way that we do our food delivery, we can't actually get staples into the diet for this ethnic group, which means they're not going to eat our westernized food when they're sick. They want the comfort foods that are appropriate for their ethnic group. Timely and accurate patient information, weights aren't typically done in most hospitals. And in fact, we're doing a little analysis comparing when the site coordinated a weight versus what was on the chart versus what was supposed to have been measured. And those things are totally inconsistent. Okay? We need effective systems, food production delivery. I'll give you an example. One of the hospitals in this study had 5 people touching the tray before it got to the patient. No wonder it's cold when it gets there. Or they have a delivery system where they gave us stories about how there's so many checks and balances in the system remove a prescribed diet, the key things that have to come out of then the standard diet, then the person's got dislikes or allergies or whatever may be going on. They might get an apple on their tray and nothing else. And there no longer is the person at the end of the tray line to say, does this make sense? In terms of communication systems, we had dietitians talking to us about how I've given a diet prescription, but I can't actually put it into effect because the way the electronic system of the medical records was working. And so that there's a delay then in the prescription being implemented by up to 24 hours because they need a cosign to do it. Other ineffective systems would be some of our hospitals have food no longer prepared on site. And so food is brought from 2 or 3 hours away. They can prescribe a diet at 11 in the morning. It might not be until the next morning that that prescribed diet is implemented because of where the food is provided and the delay in the system. Okay? So we need effective systems. We've lost sight of some of those things. Care needs to be responsible for the patients. We need flexible food systems. How many hospitals have ward stock in this country? Not many anymore. Many don't even have kitchens. And so you've got a patient who comes out of surgery, might be interested in eating. They can't get anything until the next morning, perhaps, because there's absolutely nothing to give them. The right person also needs to be delegated to right tasks. We do not need nurses opening food packages. We do need nurses getting a patient positioned right and assisting them if they need it in terms of eating, hand-over-hand eating assistance. So thinking about who in the system can do what piece is needed. So summary of this other data, food intake in hospital is an important marker of risk and recovery. Many factors influence this. There's an interest among physicians and nurses to address the nutrition problems of patients. Nutrition screening and assessment should be done upon admission, but education is required on what to do and how to do it. And there's lots of other things that we need to do beyond screening and assessment. Right? Changing the nutrition culture involves a multi-level approach, right from food through to systems around nutrition screening and treatment, to thinking about how we monitor patients in our hospital. So I want to quickly switch gears to talk a little bit about the CMT tool. I'm going to try to cut it off in about 3 or 4 minutes so we have lots of time for questions. Most screening tools are quite short, and that's the point, is so that you can do them on everyone very efficiently. And so we looked at what was out there already in terms of use of tools and looked at those that were similar to what we thought was good practice, identified some deficiencies in them in terms of the wording perhaps, the way they calculated BMI, and identified we could perhaps make some improvements. So we did that in the initial large study and had the site coordinator basically comparing that to the SGA as well as the NRS 2002. You're going to say right there, that's a criterion bias. I understand that. And most tools are actually done just at that level. We have a sub-study that's just now being analyzed that does it in the actual practice, the way you'd want it, which is nurses doing the actual screening and comparing it to SGA. So the reason why I wanted to do this is see how this compares to the 2002 and would it be any better potentially than what's out there. And we did our calculations with and without BMI, because BMI often is the stopgap because it can't get a weight or height for patient. So we basically identified that the criterion validity compared to SGA with our screening tool, which is BMI, appetite, and weight loss, has a higher sensitivity than the NRS 2002, which is used predominantly in Europe, which has a sensitivity of 61%. And when we remove the BMI, it doesn't affect the sensitivity very much. So you don't have to do a weight and height to do that initial screening if that is a stopgap for a facility. So where are we at now? We're actually doing a sub-study. We're trying to conduct it the way screening should be conducted, where we have frontline personnel determine the reliability between 2 nurses to see how it compares to SGA done by a dietitian. And we're just in the process of analyzing those results. We also have comparison to other factors. What we know is that BMI does not affect the sensitivity at this point in time, and nursing staff that have used the tool say it's very easy, these 2 questions to include. So where are we going in terms of CMTF? We've been mindful of throughout this entire process that we did not just want to do a study and stop. We recognize that the acute care community needed support in terms of making change. And so that's one of the reasons I'm here today. But also throughout the process, we've been engaging with stakeholders to identify what are the priorities we need to be working on. And as a group of individuals who have expertise in this area, how can we support those in acute care to move forward? And so these are the 6 priorities identified with a stakeholder engagement exercise in 2011. The 2 that are in blue are the ones that were identified by these stakeholders as key that we need to move forward on. And those are developing a mandatory screening program. And when I say screening program, I don't mean just put the screening tool in and stop. It has to be mindful to think about what do we do next. And the next is not necessarily everybody sees a dietitian, because that's going to overload the system. There's other things that can be done to meet the nutrition needs of patients. The other thing that was identified was that this has to be interdisciplinary. It can't be left at one disciplinary doorstep to deal with this issue. Everybody has a stake in this if we're going to deal with it. Physicians, nurses, diet techs, porters. It's not one single disciplinary group that needs to fix this. Cooks in the kitchen, if you've got a kitchen. So in terms of our knowledge translation plan, it's quite extensive. Publishing results is obviously key for us. We're in the process of writing up things. We'll hope to have a media campaign next year, early in the year, conference presentations. But key things we're wanting to do are things that will help acute care. So are there things that you think would be very helpful to you? We'd like to know about it. But we're putting things like our slide deck will be up on our website in the new year, putting up briefing notes about our findings, putting up resource toolkits, what are the best things already out there that could be implemented, giving you access to those sorts of things. And then, of course, we're also thinking about facilitate culture change, because to change a culture takes time and effort. It's not going to happen overnight. And so we're offering the opportunity to talk through how you might do that with our coordinator, our executive director, say, as well as CMTF members. This is our current website. It will change dramatically by March of 2014 in terms of content. Look and feel hopefully be the same, but there'll be lots of things on there in terms of knowledge translation to support you and your colleagues. So thank you very much.